Diagnosis Glaucoma with your hosts, Dr. Mona Kaleem
and Dr. Harry Quigley.
Greetings! Today we are very pleased to have our special guest, Dr. Leon Herndon. Dr. Herndon is the Chief of Glaucoma at Duke University and the President of the American Glaucoma Society. Dr. Herndon, can you please tell the audience a little bit more about yourself?
Hey, Mona. Great to be here. I have been at Duke University for almost 28 years. I trained at UNC Chapel Hill, where I did my undergraduate, my medical degree, and my residency. And then I went 8 miles down the road to Duke University, where I had my one-year glaucoma fellowship and then joined the faculty. And I've been on the faculty at Duke almost 28 years. I've been chief of the glaucoma division for over 10 years. And I'm really pleased to have that opportunity to help lead the next generation of glaucoma specialists.
And just out of curiosity, what piqued your interest in ophthalmology and in glaucoma in particular?
Well, I always knew I wanted to be a doctor. I didn't know what type until ninth grade when I got my first pair of glasses. I'm very nearsighted. And even to this day, the first thing I reach for when I wake up is my glasses. And when I get my first pair of glasses, Mona, I could see the world clearly. And at that moment, I think it solidified for me that, hey, I want to help others see clearly and help others to maintain their sight. So early, I would say in ninth grade is when I started thinking about ophthalmology as a profession. As far as glaucoma, we're all our mentors are really influential in what we decide to do. Sharon Friedman was my attending at UNC Chapel Hill at the time. She was our pediatric attending and also our glaucoma attending. And I just had a special connection with the glaucoma patients in her clinic. And that's when I started to consider glaucoma as a long-term career for me.
And as a practitioner, do you see a lot of family members come in? Like you see families where one person has a diagnosis of glaucoma and then another family member decides to start seeing you as well?
Yeah, I've been doing this long enough where I have children of patients that I first met several years ago. And so that's a very common occurrence in my practice. As you'll see, Mona, the longer you practice glaucoma, the more likely you'll get family members and children of your patients to come in to be treated by you. So it's a special thrill, special honor to be a part of their lives.
And glaucoma can be caused by so many different factors, but the major cause of glaucoma is called primary open angle or primary angle closure. Just out of curiosity, Leon, with regards to genetics and inheritance, how often would you say that glaucoma is inherited? I mean, is this like a disease where if you have a family member who has glaucoma, you would recommend getting an eye exam?
Clearly, the main form of glaucoma, POAG or primary open angle glaucoma, does have a big familial or hereditary component. I think the best work looking at this goes back to the late 1990s. The Rotterdam studies, which showed that family members have up to a 10-time greater risk of developing glaucoma compared to those who don't have a family history of glaucoma. So we clearly know that glaucoma, particularly primary open-angle glaucoma, does have a strong familial component. And that's why it's so important in our practices to let patients know that they should be reaching out to family members to let them know of their diagnosis.
What about angle closure glaucoma? Is that also inherited, and do you recommend getting screened if you have a family member with that?
Angle closure glaucoma doesn't have the same inheritance pattern. The inheritance isn't as strong, but still, if you do have a family member with angle closure glaucoma, I think it is prudent to be evaluated as well.
And you mentioned the word, or we've been talking about primary glaucomas. There's also glaucomas that are not primary. They're considered secondary glaucomas. Are those usually inherited, or what's the mechanism of getting glaucoma in a secondary fashion?
Variable. There are several secondary glaucomas, such as exfoliation syndrome, pigmentary glaucoma, most of which don't have as strong a familial component. There's been some work with exfoliation syndrome that demonstrates it tends not to run in families. But any form of glaucoma, many times patients don't know what type of glaucoma they have. But I think it would be safe to say that if you have a diagnosis of glaucoma, then please share that information with your family members.
Mm-hmm. Like, for example, I have some patients who they develop glaucoma after trauma to their eyes. And we think that there's probably some predisposing risk factor as to why that patient got glaucoma, because there are other patients who have eye trauma and don't develop glaucoma. So I agree with you. I still tell people, even if they don't have like a primary open-angle glaucoma, they have one of the secondary glaucomas or a glaucoma that was caused by, some non-inheritable factor. I tell them they should still tell their family members to get screened because they may be some predisposing factor that we just don't know about yet.
Absolutely.
And there's also glaucoma that someone can be born with, like a congenital glaucoma or what we call a juvenile glaucoma. Can you talk a little bit about those?
Yeah, I would say that JOAG or juvenile open-angle glaucoma does have a familial component. In fact, the probably the most noted genetic determination of juvenile open-angle glaucoma is the myocilin gene component, and so that's been shown to be linked to juvenile glaucoma. So juvenile glaucoma is similar to POAG or primary open-angle glaucoma, but just by its name, it occurs in younger patients. Usually has a bimodal distribution. You can see it in patients in their late teens and also patients in their 20s and 30s, usually associated with very high eye pressures with significant glaucoma damage. So JOAG or juvenile open-angle glaucoma is not as common as POAG. And I think that you bring a good point, because I'm often asked, when should family members or when should people be screened for glaucoma? If you look at the data, we're finding more and more that younger patients, particularly African American patients, are detected in their 20s and their 30s with a severe form of glaucoma. It used to be that everyone should be screened by the age 50, but I think we can look at, particularly in some groups like African Americans, that they should be screened as early as 30 in my practice.
Right, very good point. You're bringing up the fact that there is a racial disparity with the prevalence of glaucoma. Can you actually just comment a little bit further on that?
Yeah, much of the work came out of your shop there at Wilmer, Johns Hopkins. The Baltimore Eye Survey, Baltimore Eye Study 40 years ago was a very well done, large study in East Baltimore that showed that African Americans had 3 to 4 times greater risk of developing glaucoma than their white counterparts. And so from the Baltimore Eye Study and other studies, epidemiological studies, we know that African Americans have a greater risk of developing primary open-angle glaucoma, even at an earlier age.
And, I get this question sometimes. If your husband or wife has glaucoma, what are your chances of getting it?
The risk is mainly from a first-degree relative. So if your husband has glaucoma or your wife has glaucoma, it doesn't convey a particular risk to you.
Great. Yeah, I just wanted to clarify that point because a lot of people do ask, can you just pick it up from someone? I mean, this is not like an infectious disease. It's something that can be inherited or occur as a result of something that happens during your lifetime.
Correct.
And so you talked about the time to get screened. So do you tell people if they're African American to get screened around the age of 40 or based on just family history?
I think family history is important, but based on some work we've seen recently from large databases, I think African Americans should be screened as early as 30. That's not anything that the Academy or anyone has noted in their recommendations, but having seen so many younger patients, particularly African American patients, I clearly state that it won't hurt to get an earlier screening. Because as you know, Mona, glaucoma is often not associated with symptoms until late in the disease process. And this is, we're dealing with irreversible vision loss. So the sooner that you can detect glaucoma, the better, so that one won't continue to lose vision.
And just tell all of our listeners, if they want to get screened for glaucoma, what test should they be asking for?
That's very important. I think your listeners shouldn't think that they've been screened for glaucoma just when they go to get their eyeglasses checked or just getting their pressure checked. I think that's a false sense of security if someone comes and tells you, well, I had my pressure checked, it was in a normal range, and they say I could go another 5 years. The best way, and I tell my trainees all the time, to make a diagnosis of glaucoma is to look at the optic nerve, because the optic nerve is what is affected by relatively high eye pressure. There are characteristic changes to the nerve that we look for in patients with glaucoma. But that isn't always practical in glaucoma screening events. Mona, I'm sure you've been involved with glaucoma screening projects over the years, as have I. Have been involved with screenings in churches and other high risk, and bringing patients with high risk to those venues. But one of the main problems is if you identify somebody as a suspect for glaucoma and you recommend that they be followed up for a full definitive evaluation, many times they don't show up to be examined. In fact, some work again now, the Johns Hopkins, the Hofberger project, showed that very few, only 30 to 40% of patients or potential patients in screening venues showed up for the definitive examination. So we definitely need better methods, better ways to screen for glaucoma. There are, you can check eye pressure, you can look in the back of the nerve, you can have a patient do a visual field test. But really the key is to get potential patients in for a full evaluation.
Yeah, I agree. A lot of people think that glaucoma is just caused by an elevated eye pressure, but we know that you can still get glaucoma when you have a quote-unquote normal eye pressure, and we're still trying to figure out what is quote-unquote normal for pressure, because it can actually be very different per person. There's so many things with glaucoma, with the mechanisms we're trying to determine. And so I have a lot of people who have come to me and said, well, I had a normal eye pressure, and so no one ever told me that I had glaucoma. And so you bring up a very good point about getting testing, getting a dilated eye exam. I would recommend that to take a look at the optic nerve. There are actually some tests online. I don't know what your thoughts are, but where people can check their peripheral vision or their contrast sensitivity. And it's something that you can just set up an account for on the internet and do yourself. Those are not necessarily validated ways of quantifying peripheral vision loss. And I don't know if you tell any of your patients to do that, to take those tests, but there are some tools out there. Just out of curiosity, do you have anything like that, Leon, or do you tell your patients to try any at-home testing?
Yeah, I think the key you mentioned, Mona, is that these have not been validated. And so you can find anything on the internet, but I have not added that to my recommendations for my patients. I think more and more things will be done at home as far as following patients. As you know, there's a great way to check patients' pressure at home. There's something called an eye care tonometer. That's been validated, and many of my patients employ that instrument so we can get different measures of pressures throughout the day. But as far as a screening piece online, I've not found any that I feel comfortable enough to recommend.
I do actually have one that I like. It's a measure of contrast sensitivity. It's called the Sparks Contrast Sensitivity Test, SPARCS.
Huh.
It was actually created by Jesse Richman and George Spaeth.
Uh-huh.
Jesse Richman was a fellow of Spaeth, and they came up with this tool together. But during the pandemic, I actually did have some patients, during the active years of the pandemic, the really bad years when people weren't coming in, I had some patients take this test from home just to monitor their contrast sensitivity, because that's one of the first thing that goes with glaucoma, but we don't often check it in the office.
Interesting. Okay, I'll have to check it out.
And then another thing that I tried looking at is the Melbourne Rapid Field Test, which again can be like download it online, or there's another one called Peristat. It's just like a way if you're like in a remote place or you have some major difficulty getting in to see an eye doctor and you want to try to see what's going on with your peripheral vision, you could try taking one of those tests. But simply if you have a harder time, like you notice that you're not seeing things on the side of your vision as much, or maybe you have like blurred patches, or it's harder to drive, like you're having a hard time seeing the cars on the side, those are ways to detect if you have some peripheral vision loss there too. All right, so Leon, I'm going to ask you then, if I'm a patient of yours and I'm coming in as a glaucoma suspect and you find that I don't have glaucoma, but I'm just a glaucoma suspect, would you recommend that I start treatment?
Typically not. I typically don't start treatment unless I feel the patient's at a particularly high risk. Certainly if they have a family history of glaucoma blindness, if they have thin corneas, if they have something called a corneal hysteresis that is low. So all those factors add up. When we look at risk stratification, we try to determine which patients are at greater risk of having vision loss over their lifetime. But if I have somebody that I'm particularly concerned about, I may start treatment, but more than likely I'll just put them under closer surveillance. I'll see them back in 3 months to get another baseline, and again every 6 months or so. I typically do not start treatment unless there's significant high eye pressure, typically over 28 millimeters of mercury in my practice, or they have any of the risk factors that I mentioned earlier.
So is family history alone a strong enough risk factor to start treatment?
I don't think so. We have so many patients who have a family history, as you might imagine, with the Rotterdam studies that I mentioned earlier. So just having a family history is not enough in itself to start treatment, but it is enough in my book to start to following patients a little more closely.
And for your patients that you actually do diagnose with glaucoma, what do you tell them in terms of talking to their family about their diagnosis?
Well, I think it's really important that family members have conversations with their family members. There is some stigma, I'm told by some patients, of letting others know that they have glaucoma, maybe on their job, concerns about not being able to keep their position. But among families, I think it is important to let your family member know that you have glaucoma so they can be screened appropriately. There was a study out of Johns Hopkins, and Johns Hopkins actually has done a lot of the work, as you're hearing, with screening for glaucoma, where they looked at patients or probands, and they also looked at family members, and they interviewed the probands and the family members. Both groups were pretty aware that glaucoma is related to an older age. But one thing that was interesting in the study, only 2/3 of the patients, only 2/3 of the probands recommended that family members have an eye examination. And so I really think we need to put that number to 100%. I think if you are diagnosed with glaucoma, I think it's really crucial to let first-degree relatives know of your disease.
I completely agree, not only as a glaucoma specialist, but as a daughter, a granddaughter, a niece, a relative of many people with glaucoma. If you've been diagnosed with this condition, you should tell your relatives because it is a chronic condition. It causes progressive vision loss, and you could really help someone just by passing this information on to them. I can't tell you how many patients I have when I ask them, do you have a family history? And they say, well, we don't really talk about things in our family. And there's nothing to be ashamed of. It's you can really help someone out.
Along those lines, Mona, if I could talk a little bit about an initiative that we're doing at the American Glaucoma Society level. We are implementing an initiative called the AGS FEELS, FEELS project, which is the Familial Empowerment and Education to Launch Glaucoma Screening Program. I've been president of the AGS since March, so over the past 6 to 8 months. One of my initiatives has been to increase the screening of glaucoma among first-degree relatives. Little did I know, one of our colleagues, Natasha Kohlemeyer at Wills Eye Hospital, also had that interest, and she has actually developed a platform to allow for screening of first-degree relatives. In fact, Natasha was awarded one of our research grants through the American Glaucoma Society 2 or 3 years ago. And what this is, it's an opportunity to reach out to first-degree relatives, and we think it's a seamless fashion. A patient will come to see us. They'll pull out their smartphone. There'll be a QR code on the wall. You scan that. And that will direct family members, first-degree relatives, to a site that has A, education about glaucoma, and B, an opportunity for family members to be screened by a local American Glaucoma Society member. Natasha has some pilot data that looks very promising out of Wills, but we would like to really take this nationally and allow every patient to be able to share this information with their first-degree relatives, because as you know, Mona, half the people who have glaucoma don't know they have it. And if we can get patients in the process in the system sooner, then they're likely not to lose their sight. So we're really excited about this initiative. We hope to roll this out by our annual meeting in another few months, but this will be a way, I think, of really detecting those who have not been detected.
I'm excited about that too. I didn't know about that project, but that sounds very promising. The American Glaucoma Society is doing a lot of great work. You are the president of this organization. Please tell us a little bit more about the AGS. Can patients be involved, or what resources can patients access from us, from the American Glaucoma Society?
Yes. So the AGS was founded in 1986 by 13 founding members, and I am happy and honored to be the 21st president of the American Glaucoma Society. We have several initiatives. We plan to reach out to patients. So it's one thing. Another focus that I have is to be more patient-focused, patient-facing. And so with our new website design and this Fields project, we're going to allow patients to contact us directly on our website. There'll be areas that patients can communicate with us. Even our annual meeting coming up in a few months, we'll have an opportunity to have a patient-physician interaction. We're going to have a patient-focused education program at the beginning of our meeting. So we really believe in education, increasing patient awareness of this disease, and we're going to make it an opportunity for patients to interact with the glaucoma specialists. So there are over 1,600 members in the AGS. Most glaucoma specialists in the United States are part of AGS. And we're really excited about opportunities to increase the awareness of glaucoma.
Great. I also wanted to put in a plug for the Glaucoma Research Foundation. They also do a patient summit every year, usually on the West Coast, and this year in June of 2024, they're going to have one on the East Coast in Philadelphia. So please look out for information about that from the Glaucoma Research Foundation. Leon, thank you so much for joining us. You are such an accomplished person, but please tell us, how can we support your work, and also how can someone make an appointment with you?
Yeah, I would say that the best way to support my work is through the American Glaucoma Society. So I would go to just Google American Glaucoma Society, go to our website. There's some opportunities, number one, get some more information about glaucoma, and number two, to find ways that patients and family members can be involved. As far as seeing me, I'm pretty busy, but I always, like you, I'm sure, Mona, I always like seeing new patients, and the challenge of helping patients. And the best contact would be our development officer, Tori Hall. So she has a simple email, Tori, tori.hall@duke.edu, tori.hall@duke.edu.
All right. Thank you so much again, Leon. This has been such a pleasure. And to all the listeners out there, thank you for listening. Thank you for your continued support. And we look forward to having you on our next episode. Take care.
Thank you, Mona.
Thank you for joining us. Until next time, your mom says take your drops.